Hi everyone. Davinder, can you give me the thumbs up if you can hear me? Thank you. Thanks. Hi everyone. Sorry we're a few minutes late. We had just a bit of a technical hiccup this morning. So it's lovely to be here with you. Thank you for joining us. And welcome to this webinar today, which is looking at how we can move people with a learning disability out of long stay hospitals. My name is Julie Bass and I'm the Chief Executive here at Turning Point. This is actually the penultimate webinar in a series of webinars that we've been running, seven in total actually, which are part of a programme to mark Turning Point's 60th year. And we're really pleased to be bringing a number of really important topics into public debate in our 60th year. It seems the right thing to be doing. So since we were founded in 1964, Turning Point has grown year on year, and actually last year we supported over 197,000 people. Over recent years, the number of people that we support to make the transition from long stay secure hospitals, many of whom have been living in hospital for decades, has grown and grown, which is a fantastic thing actually, because we need to be getting more people out of hospital. In our 60th year, as we reflect on how much society and the health and social care landscape has changed, we also look into the future. And this webinar series is really designed to do just that, to look at some of the big challenges facing the sector. One of the challenges, which I'm sure I don't need to tell many of you about, is that despite scandal after scandal, the number of autistic people and people with a learning disability that continue to be locked up is way too many. And being locked up, there are increased risk of isolation, over-medication, and at times restraint. And despite repeated government commitments to move people with a learning disability and autistic people out of hospital, around over 2,000 remain there. Reform of the Mental Health Act, which was brought back onto the agenda in the King's speech, could mean that this group could be detained, might not be detained based on their learning disability or the fact that they're autistic. And the Safe and Wellbeing reviews that were conducted in 2023 concluded that 41% of autistic people and people with a learning disability detained in hospital did not need to be there. So the question is, how can we unblock the system? And I'm really delighted that today we have with us Professor Robin Miller from the University of Birmingham. Thank you for joining us, Robin. Robin is Professor of Collaborative Learning in Health and Social Care in the Department of Social Work and Social Care at Birmingham. He's also co-editor-in-chief of the International Journal of Integrated Care and the UK Demonstrator Model Lead for Impact, an ESRC-funded research centre focused on improving adult social care. Thanks, Robin. We're also joined by Davinder Jhuty. Davinder is the National Head of Service for Learning Disability at Turning Point, and she's got over 15 years' experience of leading social care services for people with learning disabilities, including day opportunities, supported living and registered care homes. So currently there are over 2,000 people with learning disabilities living in long stay hospitals across England, and this is what we are focusing on. I'm going to ask the panel to make some opening remarks. I will then probably ask a couple of questions myself, and then there'll be obviously an opportunity for all of you to ask questions. So please do note your questions down as we go. As we proceed, if you have questions and comments, can you add them to the Q&A? There's a Q&A symbol at the top of the screen. If you click on that, you can ask your question. Please do say who you are and where you come from, and you can also respond to each other's questions and comments if you want to get some conversation going that way. Unfortunately, you can't ask your question verbally because the webinar format doesn't allow, but we'll be keeping an eye on the questions and hopefully get an opportunity to ask them on your behalf at the end. But just before we begin, we are going to run a short film and we're going to hear from Olivia. Olivia lived in long stay institutions for 45 years. In hospital, she couldn't have her own things around her. She couldn't go out when she wanted. She couldn't have a pet. She was allowed out once a week, but often that leave was denied her as a punishment. The difference we have seen in Olivia since she came out of hospital is frankly remarkable. When she was first referred to us, she was assessed as needing 3-to-1 support at all times. But a bare few months later, this was reduced to 1-to-1 support, and she is able to spend periods of time on her own, which she really enjoys. So let's run the film and hear from Olivia herself. Gemma, are you able to run the film? Perfect. Thank you.
Hello, Olivia.
Hello.
Hello. Would you mind telling me how long you spent in hospitals?
I've been in hospital for about 45 years.
That's a really long time, isn't it?
In
So
different hospitals. I've been travelling all around.
all around the country, in different ones.
Yeah.
And so the last time you lived out in the community in your own home was about 45 years ago.
Oh, yeah.
So can you tell me what it was like when you were in hospital?
I didn't like it at all. Because you couldn't have ornaments, you couldn't have china, you couldn't go in the kitchen or nothing. So I went to Cedar House and I stayed there for roughly about 9-10 years. I felt really bad because you used to get wee everywhere, you used to get poo or in the bath. I didn't like it at all, it was filthy. You couldn't go out, only once a week, do your shopping. Then you only got about 3 to 4 hours to get there and back.
So how does it feel now that you're living in your own home?
I love it.
So tell me about what you love.
Now I can have everything. I can have ornaments, I can have glass stuff, I can have china, I can have cutlery, I can make my own drink, I go to bed when I want.
Did you not go to bed when you wanted in hospital?
No, I have certain times to be in bed.
Did they wake you up at certain times as well?
Yeah.
What do you like best about living in your own home?
I've got a cat, which I like, named Bonnie, and I like her a lot.
You rescued Bonnie, didn't you?
Yeah.
And you went to go and choose her, didn't you?
I did, yeah. I looked at 2, but one was only a kitten, and it wouldn't come to me, so I thought, oh, why won't it come to me? Don't like me or something.
So Bonnie chose you then,
Yeah.
really, didn't she?
Yeah, she's meowing at the door straight away.
Does she cuddle up to you?
Yesterday was the first time she slept across my legs.
Is she? She's a lap cat then.
Yeah,
And how is it having Bonnie in your own home?
I love it. I can't wait to go on my holiday on Friday.
So tell me about your holiday.
I'm going for 2 nights on my holiday to Dymchurch. I just can't wait for it. Because last year, Dr. Olsen was my doctor at the hospital. She did write to the Home Office about it, and that's if she gave me some time on holiday, but they said no, the Home Office. So we got let down, so I'm going this time.
And when was the last time you went on holiday?
About 50 years ago.
So are you excited about your holiday now?
I am.
And what are you going to do on holiday?
I'm going to go into caravan when we get there. We're going to sort all our clothes and everything out and get it all sorted out. Then we're hoping to go out for a meal and perhaps go, for a little drive somewhere around. Then the next day we're hoping to get up early and go like second-hand shops and arcades and that.
So how did you feel when you were told that you were moving to your own home in the community?
I was happy and I couldn't wait. I used to say to Dr. Lawson, have you heard anything yet? Have you heard anything yet? Am I moving yet? I was going, not yet. I've heard nothing yet. Then this come up. They come and told me straight away they're going to start coming to see you, you know, quite soon. The people, so I thought, oh, lovely. When it, you know, they were telling me about it and that, each day I was going, is there anything yet? Is there anything yet? Am I moving right now? Have we got a date? And she's going, no, not yet. I'm going, well, hurry up then. Like that, and she goes, all right, well, hurry up. So we're trying to get it pushed along a bit more.
What would you like to do in the future? Would you like to do any volunteering jobs?
Yes, I love to work at the church place on, you know, helping them to put stuff out and that, and price of stuff and stuff like that.
And you've been to see the local church, haven't you?
I have, yeah.
And what's happening with that?
Well, when I come back off my holiday, I'm hoping to go and, you know, try it out. I'm very, very happy and pleased I'm out of hospital and living out here in my own flat with my cat, with my stuff what I've got around me. It could be no better for me.
Well, thank you, Olivia. It's been lovely talking to you.
Yeah, thank you.
You're on mute, Julie.
Sorry, thank you. Thanks, Robin. Thank you for running that film for us, Gemma. I mean, it's heartwarming and heartbreaking, I think, all at the same time watching that. You know, it's how many people are in hospital who could be living a life like that. How much sooner might we have got somebody like Olivia out of hospital to enjoy more years of being able to go on holiday, going out, enjoying a pet. I mean, you know, it's so many emotions, isn't it? So, yeah. You just feel like you need to take a big breath when you watch something like that, don't you? And just settle. It's just tough, actually. Robin, can we come to you for your comments, please?
Yeah, no, thanks, Julie. And as you say, what a profound film, and it is fantastic. Olivia's been able to have the experience of being in her own place and having her pets and going on holiday and choosing what activity she wants to do during the day. But what a crime that it's taken her so many decades to be able to get to that point. And I thought it was very poignant, you know, when she was saying, she kept asking, when am I going to move? And there was no date in mind. And that was very much a similar experience to what we found in our research. And as Julie pointed out earlier, so I'm part of the University of Birmingham, and we completed a research project with Changing Our Lives, the rights-based organisation, because we wanted to really understand what is the current experience of people with learning disabilities and or autistic people who have experienced a long stay in hospital. And whilst this is something that we've all been aware of for many years, there's not been any formal research project which has really captured the viewpoints of the people, the family, and the professionals who support them, both in the hospital and in the community. And we thought that was a real gap because, you know, we know that we're trying to follow evidence-based policy making and evidence-based investment. So if we haven't got any evidence to support the challenge that people face, it's then very hard to argue that the evidence says that we should do something differently. And like many others in the research team, I was motivated by having had some contact with people who've had such experiences over a very long time. And my first job in social care was working in a residential care home in Edinburgh, where there were 10 people who'd been in the local long stay hospital for 20, 30 years. And I remember just as a young person starting out in my career, just what a travesty it was that those people had either been left with trauma that informed their behaviours and their communication, or just had lost their lives and missed the opportunity to have relationships and to follow their activities and their dreams for no reason other than they had a learning disability. So in the research project, we looked at 3 different assessment and treatment sites. 2 of the NHS and 1 was a private, was a charity-based assessment treatment. And we basically spoke to people on 2 occasions over the research project, and then spoke to their families if they were in contact with their families. They were happy for us to do so. And we spoke to the professionals on the ward. We spoke to social workers and commissioners who were concerned with the care as well. And I think it's fair to say that some things had got better from 30 years ago when I first started in this work, and that there was a general consensus that people didn't need to be in these long stay institutions, and it wasn't a good place for them to be, and that people could be better supported in the community if the right accommodation and the right support was there. And that wasn't the case 3 decades ago. There wasn't such consensus that actually that was the model that we should be able to provide for people, and that people could be supported if we had the right accommodation and care in place. But there was also a depressing familiarity, I think, with what we found prevented people from leaving. We found many examples of poor collaboration between hospital and community. We found disputes in terms of health and social care funding. And the overall sense people had was they just weren't clear what it was they had to do in order to be able to leave the setting that they were in and move into a more community option. People talked about having to jump through hoops on a regular basis and not being quite clear when those hoops would stop. We found people who were very much feeling they had to comply with whatever they were asked to do because they were worried that if they did something wrong, it would block their copybook and they wouldn't be able to move on into the accommodation that they chose. And really, where people were able to move, and a few people were able to move during the course of the study, it came down to having somebody who was in their corner. And that could be a family member, it could be a nurse on the ward, it could be a social worker, it could be an advocate, it could be a lawyer. But it needed somebody who was able to just keep the pressure on the inpatient teams and the community-based teams and the commissioners to really think about this individual and to try and explore options and to try and overcome the barriers that came up. And our sense was that it was great that those people had somebody in their corner who had the energy, the commitment, the ability to advocate, to assert, and to make things happen. But it doesn't work as a system if you need that special person, because most people don't have that special person. And for those people, they were languishing for months, really, and years, and beyond what was actually in their benefit and what was required. And they were accumulating more labels, additional traumas, and further behaviours that others found difficult that would then prevent their behaviour, prevent their discharge into the community setting. So there was a depressing familiarity with some of the challenges been there for some times, but also some examples of where they were overcome and people were able to move on. And that's, I think, what we're going to focus on today, Julie, isn't it? What can we do to make the system more better? So I'll stop there and then we can pick up more details of the research as we go through the discussion.
Thank you so much, Robin. Excellent. Can we move on to you now, Davinder, for your opening remarks? Thank you.
Yeah, thank you very much. And it was interesting because when I was kind of thinking about this webinar, it reminded me of all of the different stories that we've heard over the years, in terms of Winterbourne View is there, Causton Park Hotel, Wharton Hall. And, what was interesting to me was that, over 13 years since the Winterbourne View abuse scandal, the NHS digital transformation assurance data shows that there are at least 2,015 people with a learning disability and or autism still in inpatient units. There are 6,320 reported uses of restrictive intervention in 1 month, including chemical, physical and mechanical restraint and people being kept in isolation. Of these, 1,815 were against children under the age of 18 years old, and 155 people had their discharge delayed due to a lack of suitable housing and a lack of social care in the community. Building the Right Support is a national plan published in 2015, and as part of the Transforming Care programme, the guidance supports the NHS, local authorities and commissioners to reduce the numbers of people with a learning disability and or autism who display behaviour that challenges in mental health inpatient settings. It will enable people to live more independent lives in the community with support and closer to home by reducing the number of people in mental health hospitals, developing community-based alternatives to inpatient care, improving the experiences of people with learning disabilities and autism in public services, ensuring people have access to high quality, timely support, respecting individuals' needs and wishes, upholding human rights, and ensuring people can live ordinary, self-directed lives in their community. At Turning Point, our goal is to improve the quality of lives of the people we support. And our ambition is to support more people into the community from long stay hospitals. We've been supporting people out of hospital for many years prior to the Building the Right Support Plan, and have continued to do this work every year since. During the pandemic, I was reminded that we supported 4 individuals to move into their own homes, and this provided us with a number of opportunities to think innovatively about our discharge and transition planning, and we've continued to review, adopt and develop our processes through our experiences. We have adopted a multidisciplinary team approach where we work collaboratively with all professionals involved with an individual, from their existing support team who knows them very well through to their future support team who will get to know them well, and including property partners who will be responsible for providing their new home in the community. We used to find that trying to get professionals together in one room to gather the right information would delay our processes and therefore delay people's discharges. We have since adopted our processes to make these meetings virtual, and we ask for selected documents before we meet so we can ask appropriate questions with purpose and clarity, which overall speeds up our assessment. We are always conscious to look beyond the paperwork, medication levels and diagnosis, and understand that some behaviours that may challenge and medications prescribed can be a consequence of the environment people have been in, which is often for such long periods of time that they come with learnt behaviours. Where someone has high support ratios, we have learnt to look beyond this too, and this is often not a true reflection of need but a response to their environment, and we therefore build support reduction into our discharge and transition planning, moving at a pace that is safe, suitable and agreeable with the person we are supporting and their MDT. Having a higher staffing ratio can have benefits when someone first moves in, as this allows flexibility and support and comfort to have staff around when needed, but we are always working to support in the least restrictive way. By working as a collaborative MDT from the beginning of a transition, we are ensuring we are working to deliver the most comprehensive and sustainable person-centred support we can, which includes developing working relationships with the MDT for continued support after discharge. Gaining an understanding of what the person likes and dislikes before we meet them allows us to inform who we assign as our key workers from an early stage, to enhance the chances of success by building up trusted relationships with individuals. And we start to get to know people by working alongside already trusted and known professionals, taking our guidance of how the person wants to be supported from the individual themselves, from their MDT and from their circle of support. We also recognise that individuals would need different transitions, and we have experience of very short transitions that are only a few days long to transitions which have taken up to a year. Invariably, we see that people coming from long stay hospitals need a longer transition, and in our experience, supporting someone to come from a long stay hospital where they are used to regimented routines and very little choice and control into supported living where they may have choice and control over every aspect of their life can often be overwhelming. As part of our processes, we hold internal assessment and review meetings where we invite colleagues with specialist knowledge to be involved. And this includes our property specialists, as we recognise that getting the environment right is critically important to the success of a move into the community. And we work collaboratively with the housing provider to provide a home that is suitable for the individual's needs and which also includes any adaptations. It's essential that we provide staff with the right training before they support anyone. And we also provide staff with practical and emotional support, recognising the challenges for staff who work consistently with an individual who presents with behaviours that challenge. We train all support staff in positive behaviour support and acknowledge that every behaviour is a form of communication. If someone is showing behaviours that challenge, we need to adapt our way of supporting them to really listen and respond appropriately to them. Our bespoke community-based approach works by providing the right support at the right time to enable individuals to truly be active members of their community. And we've learned that this starts at the discharge and transition planning. It's essential to start work with the local community to overcome people's preconceived perceptions. And we do this with early engagement with the neighbours and community teams, so they get to know Turning Point, who we are, what our ethos is, and we start to build trusted relationships and create opportunities for social interaction, which in turn enables the people we support to be accepted and included in the local community. There is a lot of pressure put on support providers now. We understand that there's a lot of pressure to get people out of hospital, but we do not want to be a provider that is part of someone's cycle of trauma due to inadequate support. As a provider, we want to recognise and unlock an individual's potential. A breakdown in support doesn't stay on our record, it stays as a permanent record for the individual, which creates further judgment and questions about why they had previous placement breakdowns. And we therefore make sure that we take the time for a safe and considered approach to reduce the risk of breakdown and readmission. On occasion, transition has involved a step-down approach to supported living to enable people to adapt and learn what community living is like again. And sometimes that might be for the first time in their adult lives. Transition out of long-stay hospital will look different for every individual, and we co-produce a tailored discharge and transition plan with the individual and their circle of support, promoting their independence, choice and control from the start, always using the least restrictive practice. And where we've seen successful transitions into the community is when commissioners have worked with the local hospitals and have worked proactively to determine realistic discharge timeframes. We often see commissioners requesting bespoke packages of support to be delivered within 3 months, and it's simply unachievable because the property and the staff team alone wouldn't be ready in this time frame. That's not to say that we haven't or we won't have placement breakdowns. We have, but we've learned to have confidence in our abilities. And when we as a provider need to ask for external help, support and guidance, we empower our staff to say no when they are carrying out an assessment if they feel that we may not be able to provide the right support for that individual. And on occasion, we've declined support, recognising that supporting living isn't the right option for the individual, and we would be setting the individual and ourselves up to fail by proceeding. We actively review when and why we have said no, and we take active learning from this and picking the reasons why to see how we can improve the situation so we can say yes in the future.
Thank you, Davinder. Thanks very much for that. I think, you know, what comes screaming out to me really is the amount of time it takes, the need to focus on individual needs, you know, the resources that are required in the community, the collaboration that's needed. And I think one of the things that's come out loud and clear from listening to both of you is also the passion that is needed to make it happen by people. And also, I think the fact that getting it wrong has real consequences on the individual. And as you said, I think, Robin, you know, it's profound really to hear you say, you know, the labels and the further trauma that can be acquired over time that just puts even more barriers in the way of an individual. So getting it right is paramount, isn't it? It's just so important.
It is, Julie. One of the things that we found from our research was that because the wards were under pressure to be seen to be looking at options to support some in the community, there was a danger that they could almost do a scattergun approach where they would show that they'd approached a number of community providers. So they could say, oh, we've approached 5 people and, we've looked at different options. But where those weren't the right 5 support providers, and some of them were just never going to be the right 5 support providers because their ability to respond to people's needs would just not reflect what the person required. That again was just another source of rejection for the person, because they would know, oh, we're approaching these support providers, and they've all come back and said no. And that's really hard to hear, isn't it? That you got 5 people who've got specialist skills who are getting paid to look after you, and they've all said no, we can't do it, or we don't want to do it. And so we need to understand that emotional impact of these processes and steps, and as Davinder said, do them as well as we can, and anticipate that if we don't get them right, they're going to lead to people feeling less valued and less confident and more dejected, really, that they're ever going to be able to move on somewhere else.
Absolutely. And Davinder, I mean, in Olivia's case, for example, I mean, you were saying it can take a long time. I mean, I'm sure I was astonished to hear you say it can take a few days, because it feels like it taking a long time is almost a prerequisite, really.
Yeah, I mean, Olivia's a classic example. We were talking about that earlier, weren't we? In terms of somebody who, 45 years, I was amazed, 45 years in an inpatient setting. And she's one of those individuals that probably only lived out in the community for the first time in her adult life. And the planning and the transition is really important in terms of how we support people. And we need to make sure that we get that right.
Yeah.
Yeah, and I think part of it, isn't it, is the sort of anticipating, isn't it?
Yeah.
Well, we found some examples. Again, we did find some really good practice, so it's not to say it wasn't there, but we found some examples where thinking about what the accommodation would be only started when it was agreed that the person was in the place where they could leave the assessment treatment unit and go into the community. But then accommodation is so hard to find, and in many areas it's getting worse. It's one of the things that actually there's more pressure on rather than less, because we know the difficulties of finding affordable accommodation. So again, but that was obviously foreseeable. This person couldn't go back to where they were living before. They'd have to go and live somewhere else. So we could have started off mapping out where were the options way in advance of the day when we said, right, the person's well enough of themselves to move on, because then they had to wait months for that to happen. So there's, there is a real kind of need for bespokeness and responsiveness, but some of these things are forward planning and slightly dull but important project management, I have to say. That was another general skill that was lacking, of who is it that's actually got responsibility to project plan the contribution from the different professionals, the services and commissioners, etc., and make sure those were lined up in a way that gave the person the best chance to go in a timely manner, not a hugely delayed manner.
Yeah. And so important, when I think your report also talks about people can be well and the delay can cause them to be unwell again, actually, because of what they're having to deal with every day among other unwell people, and it can in itself make them regress, which is so sad, isn't it, when that happens? Can I ask everyone, please? I'm just going to ask another question of Davinder and Robin, but if you do have any questions, please do pop them into the chat so that we can make sure that we can address the questions that are of interest to you. While you're doing that and having a think, I was interested in exploring with you both the role of, so I think, again, we've talked already about the importance of having a champion on your side, somebody with that passion to move you out. And I know there are roles like senior intervener out there, aren't there? But what about, and not enough of them, which I think you made the point, Robin, but what is the role of families and other advocates, and what could people on this call, the kinds of people that we've got on this call, do to really support unblocking the system?
Yeah, I mean, I think advocates are interesting, and we specifically spoke to advocates as part of the research project. And I think there's just such a patchy availability of advocacy for people in these settings, and also not consistency in terms of the quality of advocacy support that they receive. So some people had very good advocates who really kind of expressed their viewpoints and didn't bring what they thought was important, brought what the person thought was important, did that over time. So there's some really good advocates out there. But there's also some examples of people just not being able to access advocates, not feeling that they did represent them, and just advocacy not really being a thing. And then the other issue I think which links to that is that often funding is such that you can access one advocacy organisation when you're in an assessment and treatment, but then as soon as you go into the community, you can't access that because the funding is only limited while you're in that setting, which is just a nonsense, really, because it's a bit like transition from children's to adults. You're transitioning from one setting with one set of professionals to another setting, and what you need is continuity. You need somebody who can say, well, look, I've known Julie for a number of years, and actually this is what's important to Julie, and Julie said this previously, so please take that on board. But again, that wasn't always in place. And so there's things like that again, it's the classic thing with integrated care collaboration. We put in a number of barriers that don't really need to be there, just because that's the way we've funded and organised it before. And I think with advocacy, that's something that we could definitely put in place. One, more capacity, one, more opportunities for advocates to develop their skills, but three, to make sure that they're able to provide that continuity that people need as they move between different settings and different accommodation options. So yeah, so it was there, but again, there's just a huge opportunity to put a bit more investment, a bit more thinking, and to enable the contribution of advocates to be much greater, and to much more to add to what the person currently has.
Yeah, I think I would also add to that in terms of the family, because the family almost comes at it sometimes from a very emotive place as well, don't they? And they probably need support themselves as well in terms of kind of understanding how they can be a part of that support for that individual, because it's a struggle for them as well. And quite often what we're doing is we are supporting families as well as the individual in terms of making that transition and making that move.
Yeah, and I mean, it does speak also, doesn't it, to that whole point about connection and collaboration, funding flows, the importance of everybody, the kind of MDTs, but also commissioners and funding all coming together at the right time, which is that forward planning piece that you're talking about as well, isn't it, Robin? I always find it interesting, that we try and move away from talking about projects and cases and because these are people with lives like we have, but at the same time we do need that kind of planning and project management to actually enable the shift to take place.
Yeah, we do. And there was one of the sites we worked with. They were bringing in a new initiative for one of their assessment treatment wards, that somebody wouldn't be accepted into the ward unless there was already accommodation option in place for when they came out of it. And I don't know, we haven't gone back to it yet to find out how that worked, but certainly that kind of basic, you only get access if you actually thought of accommodation in advance, would seem one way of just making sure there's something in place. And yeah, there has to be funding for that accommodation. But when we think about how much money is tied up in supporting people in what we recognise on a long-term basis is not an appropriate setting, as we said, it causes additional trauma. It makes it more likely for the person to be able to remain in the community long term. There is funding there, but we just need to use it much more creatively and proactively, and accept that in the short term there may be a bump in funding, but in the long term it will enable the funding to be used where it's best deployed.
Yeah, and I think sometimes in the very best, with the very best of intentions, we try when we work in this space not to talk so much about the economic case, because really we're driven by the morality and the humanity, aren't we? But actually it's true, it's also economically makes sense actually to just get the funding in the place in the community, move people out of hospital. It makes sense in every case, doesn't it, to do that?
Yep.
I just want to turn to a question that has come in from Ivan, where and it's interesting because obviously you've done the research, Robin, that we've referred to, but Ivan's saying, why has there been so little research involving people with learning disabilities and autistic people, and how has that affected the availability of support solutions in the community?
Yeah, no, thanks for that question, Ivan. And well, I mean, I think it just reflects the the structural inequalities that we have in so many parts of society. I mean, that's the bottom line, in terms of who is it that we have previously thought could be involved in research, who could be co-investigators in research projects, etc. And I think 20 years ago we were just very limited in our openness and our recognition of the ability of people with disabilities to participate in such activities. I do think that's changing. I think a lot of the research funders, like the National Institute of Health and Care Research in England, is changing that paradigm, and is positively supporting people to be able to develop the skills to both participate in research, but also to be investigators, etc. But it just takes a long time to kind of shift that dial. And it was striking to us when we looked at the research. So for an area of policy and practice that we've all known has not been going as well as it could have been, it's causing people incredible trauma and limitation in their lives. There was only 13 research studies ever done in terms of people with learning disabilities and or autistic people who've been delayed in hospital, and 11 of those were basically just looking at bed census data. Nothing wrong with that at all, but what a limited view of a very complex process. And none of them, as I said, had involved and spoken to people with learning disabilities and autism and their families themselves. So yeah, but the fact that we could get funding from the National Institute of Health and Care Research in order to carry out the research, and they've been very supportive both in terms of the methodology that we had to do and the fact that we needed to spend time to give people the space and the opportunity to think about whether they wanted to participate. Changing Our Lives were fantastic at coming up with alternative communication methods, all of which takes time and energy to design and to go up to the wards on multiple occasions to speak to people, etc. But the NIHR, to be fair to them, were very supportive of the fact that would take longer than they would expect with other research projects, and gave us the capacity and the funding to do that. So I do genuinely think there's optimism that things are starting to change, whilst also recognising, Ivan, and you raise a really important point, there's still a long way to go before we get to the point of parity of different voices being heard and leading research.
And it's good to hear that, Robin, because we need to recognise and celebrate the successes as well as, really feel the passion for making the changes that need to happen, don't we? We've got a question in here from Dave as well, Dave Lewis, who says, the research that you've done, Robin, sounds incredibly important and it's great to hear about it. How can the sector more broadly support with putting the spotlight on the findings and further influencing system-wide change?
Yeah, no, thanks for that question. And I think I would say we would absolutely recognise that we're one part of this jigsaw in terms of raising the issue and getting government and commissioners to think about it and to keep the focus on it. And so yeah, we worked alongside and on the shoulders of people who've done a lot of work before, etc. And so I think it's that. I think one is that it's having webinars like this, it's talking about it, it's raising it, it's taking it to places that integrated care boards, who are the new kind of planning system in the health and care system in England. It's making sure it's on their agenda. Often they will have, the integrated care systems in particular, will have meetings in public. It's taking the time to raise questions there. It's just keeping it in front of people. And I think we can criticise building the right support, quite rightly in many ways in terms of its obsession with numbers, not people's quality of life, etc. But one thing that it did was it really focused the minds of people who run health and care organisations. They've got a lot to think about, but it focused their mind the fact they had to keep on reporting how they were getting on, where they making progress, why were they behind their plans, etc. All that meant that they were talking about these individuals and how they could better support them and what they could do to support, enable them to go into the community on a much more regular basis than they had done previously. So I think it's all of us thinking about where do we have some influence, either through our professional life, or because we're part of Health Watch or another advocacy group, and it's keeping it in front of the commissioners, the senior managers, the politicians, to make sure they don't forget about it, because they've got lots of other things on their plate, and we'd all recognise that. But actually, there's none that is as more important than this issue and the lives that people have lost because of the poor system that we have currently.
And it's interesting, Robin, because we were at the, and Dave, we were at the Local Government Association 10 Turning Point convened a fringe meeting there on this subject actually earlier on this week, and it's really just using all those platforms, isn't it? I mean, to just try and get to the decision makers and get to the people that can actually influence either in their local geography, you know, or nationally change. Davinder, what would you say? Because I think one of the things that we believe in the sector in general is hearing the voices of people like Olivia can really help shift the dynamic. What do you think about that, or indeed any other response to that question?
I think it's really important, and I think the thing is, the thing that I talked about earlier was the fact that very often people meet individuals and they see certain behaviours and they see different forms of communication. Not everybody communicates in the same way, and we have to get to know the person to kind of really understand what it is that they're telling us. And I think often people are overlooked and not recognised because people don't understand, and they look at behaviours, they look at the fact that somebody's been in a place for a long time, and you know, we've struggled with accommodation, as Robin has said as well, you know, in terms of even housing providers and stuff, there's certain ceilings that we have to work to, so it all gets caught up. And I think hearing people's voices, what people want, how they want to be supported, it's critical in terms of the success of how we move forward.
And it's also a really interesting point about ICBs in public. Actually, I mean, it's something I'm just interested in, is how health and social care comes together through integrated care systems, and how we can get people to really understand some of these deeply entrenched problems. So I think it's a great shout, actually. You know, raising questions in those public meetings can really make a difference.
Yeah, and I was on the Health and Wellbeing Board, which is people might know as the Integrated Care Partnerships, which oversee the systems, and then the place-based coordinating bodies are the Health and Wellbeing Boards. I was on one of those for 5 or 6 years, and we only got 2 public questions in 5 or 6 years. And every time we start the meeting with, is there any public questions? The public questions we got were, I think, for pharmaceutical companies or whatever, which nothing wrong with that, but it wasn't really a public question. And they would have actually really liked it if you know, a group had gone along and placed a question to them to say, this is what really matters to us. Can you know, please tell us what you're doing and please report back on it. So sometimes, you know, those bodies are looking for a legitimacy in order to focus on a particular issue alongside all the ones that they get from government and local politicians, etc. So yeah, so like I said, it's just working out where those influencing points are, and then spending a little bit of time to kind of access them.
Absolutely. And there's a question in from Carl Howard Jones here, for which I'll put to both of you. Is there something we should do in terms of in-reach to the hospitals? If we collect the data on where people are, could we pilot something or get bid team involvement, for example? Davinder?
I mean, I think for us, you know, when we're looking at this and we're kind of saying, what are the kind of if I kind of think about it in terms of what are the kind of the main blockages that we found, so, you know, we've talked about housing, there's financing, there's staffing and stuff as well, but also there's something about kind of getting the data around discharge planning as well. You know, I talked earlier about the fact that we know we've got children coming through the system as well, but adults and children's services don't seem to have that data joined up, and they don't seem to have that. So for us, kind of looking at that discharge planning, if we had more access towards that, we wouldn't be reactive. We could start to plan towards supporting people with their discharges.
Absolutely.
Yeah, no, I totally agree with that. I think it's a really good point. And part of it is, isn't it? Again, we find just such inconsistency that we had some examples of where commissioners had worked with independent providers to say, right, so you've got the right skills and the accommodation options for this individual, so we're going to put in place funding so that you can start to meet with them over a course of weeks and get to know them and help them out. But then we had other examples of where providers were basically, you know, it was kind of, you know, 2 weeks before somebody came out, right now we'll start to fund you, which just doesn't make any sense at all. So there was some really excellent practice going on, but it was just so inconsistent. And Turning Point will know this, and when we spoke to the providers themselves, they said it did seem to come down a lot to the individual local authorities stroke health trusts, but also just the kind of personality of the commissioners and whether or not they would support that or not. So we can definitely do better in that. You know, we should be having arrangements, shouldn't we, where there is the opportunity in the space for people to get, for the providers to get to know the individual, to develop the team around them, because that's going to make much more increase the potential of them remaining in the community and not, you know, experiencing difficulties. So I think in is really important. And I think the thing is with the ward staff, it is actually quite hard for the ward staff, because particularly because as we know, people are placed all around the country in different units. You can't do it, can you? If you've got someone living in your ward, you know, somebody's from Newcastle, somebody's from Manchester, somebody's from Wigan, somebody's from Shropshire, you can't possibly know all the local services that are there. And we need to recognise that and think, well, what is it we need to do to provide a bit more capacity for the community teams to be able to come and spend time in the wards to talk about what the options are that are available. And one of the organisations we work with had employed social workers in the assessment and treatment faculty. So their job in a way was to go out and to contact the local areas and spend time and meet, etc. And I thought that was a really good sort of development in terms of having the capacity, but also making the use of the social work skills, because that was something, again, that was quite patchy in terms of the research. So there are things that we can do. We just need to be able to be willing to invest, put a bit of money in the front, and to overcome some of those boundary issues that we experience on a regular basis.
Sure. So I just want to pick up a comment and then one more question that we've had from people who are with us this morning. So Derek has turned around and has put in the chat that it's important to recognise that there are many people who we currently support who have similar histories, journeys and reputations as those we have worked with under Transforming Care, and their potential hospital admission has been avoided because of the work that's been done on early intervention, crisis, recognising crisis, building the right support, having the right staff, skills and training, resources, creating the right environments and all the right relationships, including with multidisciplinary teams and families. And I think it is important actually to recognise that, because we're seeing increasing complexity and acuity all over the place, aren't we? And this label of transforming care, or, you know, I mean, it isn't exclusive, is it? There's just so many people with so much complexity in the system.
And we have seen some tremendous positive outcomes for people that we've successfully transitioned from hospitals into their homes. And you know, there's a particular case I was just thinking about, a particular individual that I was thinking of, where actually due to kind of the reduced interventions and in line with STOMP guidance, we've supported them to have a reduction in their medication. And that includes reducing, you know, their risperidone by 33%, their diazepam by 76%, and their use of sodium valproate has completely stopped. Incidents of distress and frustration have significantly reduced, and PBS techniques are proactively used instead, and people are not being secluded where they previously have been in hospitals, and the training of staff around low arousal and withdrawal approaches in managing behaviours has been really key for us.
Absolutely, absolutely. So I think we've got time for probably one more quick question, and although as I say it, the irony of me using the word quick when I'm going to mention funding isn't lost on me actually, but so question here from Liam: is the funding needed to unblock the system from local authorities there, and if so, are there local authorities with a better model which other regions could try to implement?
Well, I mean, I think we know that the pressure local authorities are under is just unprecedented at present. I mean, it's just horrendous, and it's one of those issues, I think, where the money is largely tied up within healthcare settings, but the solution is largely within local authority and community health settings as well, because they're really important, the community health professionals. So we have got an issue there where the funding is tied up in one place and the opportunity to solve the issue is tied up is in another. So, you know, local authorities are under huge financial difficulties, but we have to see it as a whole system, and we have to see the funding as being a pot that we can use more flexibly in order to enable people to have that better quality of life. And I think, you know, we do examples of really good kind of joint commissioning, pool budgets, etc., where health and social care have been willing to put the money together and willing for it to lose its identity, and therefore to provide what's important to those people and to support those who will come through in the future. So yeah, we do know how to do this, but there's always with these things, as ever with partnerships and collaboration, there's an issue of it's very hard for people to give up resources that they currently have. It's very, very difficult. And I think most people would feel that in their jobs and their organizations. They tend to have a loyalty to their profession, to the traditions that they've inherited, and they like to see themselves having a major role going forward. So that's sometimes where governments have to step in, a bit like they did with, you know, mental health asylums going back, etc. Not perfect, but it did radically transform it. So perhaps governments need to do something a bit more directive in terms of dictating that the amount of money that should be spent in the community as opposed to in the hospital settings, and enabling local authorities to use that money more flexibly, to have some certainty about it, because there's a huge amount of anxiety, as you were talking earlier, Julie, and the LGA, etc. We've got to recognise that, because otherwise it's just not going to move on, because people have just not got the financial headroom to do it.
Absolutely. So Davinder, is there a 30-second comment you would like to make as we close this webinar?
I'd like to say that, well, first of all, it's been great to be on this, and it's a really important topic. You know, we talked about the fact that we've still got more than 2,000 people in inpatient settings, and the more that we can get involved in terms of doing that and how we support individuals and the work that we do at Turning Point as a provider, it's really important. And we want to be able to support more people out of hospitals and into community settings, and that's our ambition. And you know, it's the work that we continue to do.
Thank you, and Robin, thank you to you as well, and especially for your research and the really important work that you're doing to try and highlight this. And we're right there with you, you know, trying to make sure that we can do what we need to do. I think one of the things that I've heard repeatedly through this webinar series that we've been running is the importance of recognising people as people. You know, not cases, not numbers. It doesn't matter whether we're talking about any of the broad range of topics we've covered on these webinars. It's always about recognising people are people, not othering them, not seeing them as less than, you know, which is a sad fact, actually, that often we do come up against that. And it certainly couldn't be more true of the people that are stuck in hospital. You know, they too have hopes and dreams, and I'm not entirely sure those hopes and dreams are going to be realised if they're stuck in hospital. And beyond that, I think morally and ethically, we must make change happen faster and happen more effectively, because that way people won't be stuck in hospital for 45 years like Olivia, and they could be living a life like Olivia. So I just want to thank everyone for being with us today, and in particular, Robin, to you, and to you, Davinder, for helping us shine the light on this really important topic. And let's just keep up the fight, to be honest. Let's keep up. There are some positive things, as you've highlighted, Robin. There absolutely are. And there are more things that we can do, and let's just keep on going, because we know it's worth it. Thank you very much, and thank you all for joining us today.
Thanks all. Nice